Good afternoon, ladies and gentlemen. We are now moving to the second debate of this afternoon's neuroimmunology session in CONI 2022 Virtual Congress. The debate topic is as follows: routine MRI surveillance should be undertaken in patients with confirmed or suspected NMO spectrum disorder and MOG-associated disorder to assess disease activity. This follows from the current practice of routine MRI surveillance in patients with multiple sclerosis to assess treatment response and also to decide on treatment switch. And it has been always a very important parameter and outcome for phase 2 clinical trials. The question is whether this can be transferred as a clinical practice in patients with confirmed or suspected NMO spectrum disorder and MOG-associated disorder. So speaking in favor of the motion is Professor Paul Friedman. Professor Friedman is the group leader of Clinical Neuroimmunology Department of NeuroCare Clinical Research Center at the Charité. He finished his medical education in Berlin and is a board-certified neurologist. He has keen interest in neuroimmunology and his research focuses on neuromyelitis optica, neurodegeneration and neuroprotection in multiple sclerosis. He has been involved in a number of scientific and research activities. He is a member of the European Academy of Neurology and editorial board of clinical journals, neurology, neuroimmunology, and neuroinflammation, among others. Opposing the move would be Dr. Saif Huda, who is a consultant neurologist at the Walton Center Foundation Trust in Liverpool. He's a clinical lead for NMO UK, highly specialized service in the North Wales, and also leads the North Wales Multiple Sclerosis Service. He had completed his neurology specialist training and NMO fellowship at the Walton Center in Liverpool. He holds a DPhil in neuroimmunology from the University of Oxford, and he has been involved as a clinical investigator on several trials of NMO and MOG-associated disorder. So if Professor Friedman is with us, may I request him to wait until we have the results of the debate. So audience, could you please vote either yes or no, whether routine MRI surveillance should be undertaken in patients with confirmed or suspected NMO spectrum disorder and MOG-associated disorder to assess disease activity. Please vote now. have got the voting result. So we have 65% who have voted yes, meaning they support the practice of routine MRI surveillance in patients with confirmed or suspected NMO spectrum disorder or MOG-associated disorder, and a third, 35% voting no. So I think we are probably going to start with Professor Friedman's talk, and that would be followed immediately by Dr. Huda's presentation.
Dear colleagues, it's my pleasure to discuss with you the issue of MRI surveillance in patients with confirmed or suspected NMOSD and MOGAD to assess disease activity. And it's my pleasure to take the position of the yes argument here in this debate. Here are my disclosures. Now, let's set the scene for the questions that we want to discuss during this debate. There's a long history in multiple sclerosis, and as you know, here in MS, routine MRI follow-up is regarded as clinical standard to assess radiological disease activity and also the NEDA, no evidence of disease activity criteria. And as you know, in MS, we do use MRI surveillance to inform treatment decisions, for example, to assess failure or efficacy of a given immunomodulation. And the question now is this applicable to NMOSD and MOGAD? And before addressing this from a clinical perspective, we should discuss and look into what we have learned from longitudinal imaging studies in these conditions that inform us about subclinical disease activity. And then, of course, the next step would be to use MRI surveillance to drive treatment decisions in these conditions now that we have, at least for NMOSD, several approved immunotherapies, eculizumab, satralizumab, and inebilizumab. And there might be another reason to perform MRI surveillance, and this is for safety reasons. Now, this is just to provide you with a background in multiple sclerosis, a nice review from now almost 10 years ago, clearly showing that from the effect of a given immunomodulator on MRI lesions, it is possible to derive the effect on relapses. So this shows the clear correlation between MRI disease activity and clinical disease activity. Now, in NMOSD, we know that in contrast to multiple sclerosis, which is shown here on the right of this schematic, disability is largely attack dependent. So most attacks in NMOSD do not fully recover and leave the patient behind with accrual of disability, and there is usually no progressive phase of the disease in contrast to multiple sclerosis. And this provides the rationale for the therapeutic recommendation to start preventative immunotherapy as soon as possible once the diagnosis has been established. This is from quite old work from the Mayo Clinic showing that very few patients with NMOSD have progressive disease, and it's not clear whether progressive brain atrophy, for example, is associated with clinical progression, which means that we do need additional imaging studies to better understand the clinico-radiological correlation in NMOSD, but also MOGAD. What you can see here are typical imaging features in NMOSD. This image is also part of the paper on the diagnostic criteria published in 2015, brainstem lesions adjacent to the fourth ventricle. And this, in most cases, or in almost all cases, comes with clinical symptoms, intractable hiccups, nausea, and vomiting. So this is pretty clear that we could detect an attack or a relapse from the mere clinical presentation. However, as we have seen now from many imaging studies, the majority of NMOSD patients has so-called unspecific or non-specific lesions, as shown here. So small, punctate, usually smaller than 3 millimeters in diameter, hyperintensities on T2 weighted or flare sequences in up to 80 or even 90% of patients. They are not necessarily related to NMOSD, but could stem from age, vascular comorbidities, hypertension, and other issues, and they are considered to be usually asymptomatic. So how would this help us inform treatment decisions if we saw, let's say, new lesions of this kind on a follow-up MRI? Now, when we speak about imaging surveillance, we also need to discuss the issue of progressive tissue damage or covert tissue damage. Does this occur in NMOSD, and does this confer a risk of clinical deterioration? Now, over the past 2 years, there have been a couple of studies, for example, with retinal optical coherence tomography that has shown covert tissue damage. You probably know OCT, a high resolution technique to image the various layers of the retina, and it's easily possible to quantify the extent of neuroaxonal degeneration in the retina. That is CNS tissue, as you know. And this is just one example from many studies that have come out showing that there is longitudinal thinning of the ganglion cell layer in aquaporin 4 antibody positive NMOSD, as you can see here on the left side of the schematic. The right side, as delineated here, shows the ganglion cell and combined inner plexiform layer. So there is progressive tissue loss in the retina. It's still not fully clear whether this confers, as I said, a risk of visual deterioration, but it's important to bear in mind here that these were eyes of patients or eyes without attacks of optic neuritis. Another study with VEP data has shown that there's also VEP changes in patients without optic neuritis. This means that there's also a progressive decline of electrophysiological function in the visual system of these patients, independent of clinically overt attacks of optic neuritis. And now coming to the spinal cord, another study here clearly showing that patients, as highlighted here in yellow, who had no attack of myelitis showed a decrease of MUCA, so the upper cervical cord cross-sectional area, in comparison to healthy subjects, again arguing in favor of clinically covert or not clinically overt tissue damage. This study from Japan has shown that there is progressive brain atrophy in aquaporin 4 positive NMOSD. You can see this here on the left side, and for comparison, there are RMS patients here in this study, 3 different cohorts, and this study has shown that there is silent progression of brain atrophy in aquaporin 4 antibody positive NMOSD. Again, it's not clear whether this comes with an increased risk of, for example, cognitive decline or other clinical sequelae. Now, going to clinical trials, this study with inebilizumab, the NMOMentum study, the by far largest randomized controlled trial in NMOSD, has shown that inebilizumab was able to reduce the proportion of patients with EDSS progression over the course of the study. And interestingly, some patients obviously had progression in both groups, inebilizumab and placebo, without an attack. So perhaps there might be a smaller subgroup of patients that does experience progression independent of attacks. Now, what do longitudinal imaging studies tell us about subclinical occurrence of new lesions? And to be very frank, there are very few studies out there in this rare condition. This is one recent study from Korea showing that the frequency of asymptomatic new lesions is very small. So out of this cohort here of more than 140 patients, there were only 5 patients that had new lesions over time. You can see a few examples here. On the right side of the schematic, there were no gadolinium enhancing lesions and there were no NMO specific lesions. So as I said earlier, most NMOSD patients have unspecific lesions, and this was obviously also the case here in this study from Korea. However, there might be some patients who do show new lesions on spinal cord imaging without a clinically overt manifestation. This is the study from the Mayo Clinic describing 4 patients here, and this was then in some cases here an indication to start or to switch immunotherapy. Another study from Korea published a few years ago, again showing that some patients do show asymptomatic lesions. You can see here a few examples that then disappeared or regressed over the course of time. Again, the question is, if we detect a lesion as shown, for example, here in the left upper panel in AA, would this drive us to change treatment in these patients? Now, again, in the momentum study with inebilizumab, we have seen, that is highlighted here in yellow, that in both groups, there were patients who accrued new MRI lesions, both T1 GAD and T2 lesions over the course of the study. And then when looking at patients who did not have attacks, and this is most interestingly shown here on the right side in panel C, there was a high proportion of patients now shown here for the optic nerve imaging that had new GAD or new T2 lesions independent or in the absence of clinically overt attacks of optic neuritis and also myelitis. So this clearly shows that there does seem to be a higher proportion of patients with subclinical radiographic disease activity in NMOSD than previously believed. Now, what else could MRI do for us from a clinical perspective? Of course, as you know, there are quite some cases with diagnostic uncertainty, especially in seronegative cases when the apoPOE4 or the MOG antibody is negative, but the clinical course is not very typical of multiple sclerosis. So the question is this MOGAD, is this NMOSD, is this multiple sclerosis? And the more so, as we have seen from a recent review, that quite a few patients with apoPOE4 antibody NMOSD, but also anti-MOGAD NMOSD, or MOGAD as the condition will be called in the future, does meet imaging criteria, the Barkov criteria for multiple sclerosis, which poses a difficult differential diagnostic considerations. So MRI surveillance or repeated MRI during follow-up might help establish a clear diagnosis. For example, it's conceivable that follow-up imaging might provide us with some information about the central vein sign. You probably have heard about this, that this is a highly discriminative feature to differentiate multiple sclerosis, in which the central vein sign is highly characteristic from other conditions like NMOSD, but also sarcoid and other rheumatological conditions. The third point is that MRI surveillance can help us with safety issues. We do not know whether the new biologicals, eculizumab, satralizumab, and inebilizumab confer some risk of, for example, PML after longer periods of application. And we, again, from the MS field, have seen that early diagnosis of a progressive multifocal leukoencephalopathy with the help of regular MRI follow-ups at short intervals is very instrumental for an early detection of PML and for the implementation of appropriate therapeutic measures. Now, to sum this up, there has been a controversy in the MSJ recently about this very issue. So spinal cord and brain MRI should be routinely performed during follow-up in patients with NMOSD. Yes, no, and a commentary on this. So I think there are a few arguments in favor of regular monitoring of NMOSD and MOGAD with MRI, although there are a few still unresolved questions. So as we can see down here, MRI or subclinical MRI activity seems to be more frequent than expected. We have seen this in the momentum study, but also from other studies. It's, however, not yet clear whether subclinical MRI activity would inform treatment decisions, and we also do not know whether progressive tissue damage, covert tissue damage, which does occur, we know this from the MRI and also the OCT studies, does confer a risk for clinical deterioration, for example, cognitive decline. So we need more prospective imaging studies with regular follow-up with both ideally OCT and MRI in conjunction with also subtle clinical investigations, for example, on cognitive function, to resolve this issue hopefully over the next couple of years. With that, I'd like to thank you for your attention. I'm looking forward to the debate.
Hello, I'm Seyfrieder, a neurologist and NMO specialist from the United Kingdom, and I'd like to thank the organisers for allowing me to propose the motion of whether or not routine MRI surveillance should be undertaken in patients with confirmed or suspected NMOSD and MOGAD to assess disease activity. I have no disclosures or conflicts of interest. And I think it's important to underline a few key words in this debate. Routine. So this isn't about distinguishing relapses from pseudo-relapses, or even detecting asymptomatic changes at relapse. This is about the routine scanning of patients who have or may have NMOSD and MOGAD to assess specifically their disease activity. And we'll have to think about what we think is meaningful disease activity throughout this. Now, let's be clear. We're not doubting the utility of MRI in diagnosing these conditions. They would not be part of the criteria diagnostically for NMO and MOGAD otherwise. We also know that a static scan can be very helpful in differentiating NMO from MS in suspected cases. And again, this is a cross-sectional, not a longitudinal study that showed that the presence of a Dawson's finger, a subcortical U fiber lesion, or a lesion adjacent to the body of the lateral ventricle in the inferior temporal lobe had a high sensitivity and specificity in distinguishing NMO from MS. We can also differentiate quite reliably MOGAD from MS. And we know that the presence of fluffy lesions and relatively few are more specific for MOGAD, whereas ovoid lesions adjacent to the body of the lateral ventricle, Dawson's fingers, and high lesion lobe, more than 9 lesions, are more suggestive of multiple sclerosis. And again, we don't need routine monitoring to do this. This is off a single scan in this study. And perhaps more challenging, because there are overlapping features, but there are some features that are suggestive of MOGAD versus acroporin 4 NMO, or antibody NMO. And again, the fluffy lesions and the impotent drawing are perhaps more frequent in MOG antibody disease. There are also other features, such as bright spotty lesions in NMO, the perineural enhancement of the optic nerve, and the H sign in MOGAD that can also be helpful. And we know that, at least in the spinal cord, we can start to tease these conditions apart. In this study from the Oxford group that used a combination of conventional and unconventional MRI techniques, this was possible with, of course, whole cervical cord MTR is not something that we do routine clinical practice. And again, this is about routine MRI surveillance, and we can do all the aforementioned with a single scan. This debate is also not calling to question the utility of MRI for prognostication. We know that spinal cord parameters, such as the mean cervical cord area, modestly correlate with EDSS and 25-foot time ball. We also know there are other useful features, such as spinal cord lesion length and symptomatic brain lesions, in addition to the lesion length of optic neuritis and visual prognosis. And again, we're talking about disease activity and not prognosis. And whether asymptomatic disease activity is linked to prognosis remains to be seen. So what do we know about the evolution of lesions in these conditions? This paper for the Mayo Group shows how MS and acroporin 4 antibody NMOSD are a bit more stubborn in their temporal persistence, whereas MOGAD lesions tend to resolve more completely. This could be helpful diagnostically and has important implications for clinical trial imaging outcome measures. And it also highlights that one could potentially underestimate disease activity in MOGAD with routine scanning, depending on the timing of one's imaging. And again, to reiterate, this is assessing disease activity, not disease resolution. So now that we know what this debate is not about, let's talk about what it is about. Our primary aims in NMO and MOGAD are to prevent disability and relapses. But is it possible that you could acquire disability independent of clinical attacks? If so, there are 4 important questions. Does inter-attack change occur? Secondly, can it be detected by MRI? Thirdly, is it clinically meaningful? And lastly, will it inform patient management? Unless all 4 of these questions are met, we should really think twice before routinely scanning patients. So, does inter-attack change occur? We know that it can. In this case series from the Mayo Group, Owen Flanagan and colleagues reported patients who developed asymptomatic neuritis with seropositive NMO. Interestingly, one of the patients did develop symptomatic LETM 2 months later. And it may be that this reflects an evolving spectrum between the radiological and clinical manifestations of the disease, especially in patients on NMO treatments. In the spinal cord, things are a little more complicated, I think. In this study to the left, cervical cord spinal atrophy was noted in patients with NMO without a history of myelitis or any spinal cord lesions on MRI, and that was only after half a year of follow-up. A slightly different outcome, but looking at the cervical cross-sectional area of NMO patients without a history of cervical cord lesions, the CSA was almost equivalent to that of healthy controls, and that was after almost 12 years of follow-up. Similarly, in MOGAD patients, the CSA was similar to healthy controls after 3.3 years of follow-up. And what about in the brain? So in this study, it was a longitudinal MRI study that examined 18 NMO patients with a mean disease duration of 5 years, and they scanned at baseline and at 1 year follow-up. It was only a small sample size, but albeit that, there were no new silent brain lesions seen in the NMO group. In this subsequent study, that included 145 NMO patients and 708 years of relapse freedom, so a much bigger study, only small, non-specific changes were seen. The average age was 50 years old, so it could be argued that some of those changes could have been related to other factors such as hypertension. In this study that looked specifically at silent brain lesions in NMO and MOGAD, a large proportion of patients were again included. So in MOGAD, there were 182 patients with 167 remission scans, with new asymptomatic changes seen in only 3%. And in the NMO group, 222 patients with 269 remission scans and new changes in 2.6% of patients, so very small proportions. What's really interesting is in the MOGAD group, those who had asymptomatic new lesions developed a relapse, a clinical evidence relapse, much more quickly than those without, so 2 versus 33 months. And that was similar with the NMO group, 5 versus 85 months. So perhaps like we saw with the case series from the Mayo group of those asymptomatic spinal cord lesions, these lesions are evolving and detected in the pre-symptomatic stage. And I question whether we can refer to such cases as being truly asymptomatic. We know that treatments attenuate severity of relapses, and perhaps this is reflected in a slower evolution. Such findings would certainly be clinically meaningful, but how many scans would one have to do routinely to detect one of these? This is a really important point when considering management in resource-limited settings. Perhaps the most intriguing data comes from the N-Momentum study. To recap, this was a randomized placebo-controlled trial assessing inebilizumab in 230 patients. There was an impressive 77.3% reduction in relapses, and MRIs were performed at baseline, attack, and at 6.5 months. Interestingly, despite the efficacy of inebilizumab, asymptomatic GAD enhancement was seen in almost a third of patients, 3% in the brain, 18% in the spinal cord, and 51% in the optic nerve. Perhaps with highly effective treatments, we are attenuating but not abolishing the pathogenic potential of anti-inflammatory antibodies. And what we are seeing here is the MRI equivalent of this. I wonder if we would see the same changes with a drug with a different mechanism of action, for instance, eculizumab. Whilst this certainly raises important questions about the spectrum between blood-brain barrier breakdown and clinical attacks, at present I think it warrants further research rather than a paradigm shift. We have to ask ourselves, are these changes clinically meaningful? Is it something we should be treating acutely or escalating our drugs in response to? The answer is, we don't know. And we need to undertake studies rather than change our routine clinical practice to determine this. Otherwise, we may run into the same problems we currently experience in MS management. And if we're going to do these studies, we have to also ask, is MRI the best tool? We know that MR-negative myelitis can occur. And we also have seen that MOGAD lesions can dissipate with time. We know that there is progressive prolongation of visual evoked potential latency, and that over time, subclinical changes occur in contralateral eyes of NMO patients who have had optic neuritis in the GCIP layer. There also may be a signal towards grey matter involvement that could relate to cognitive impairment. Interestingly, there does not seem to be much elevation in the highly regarded serum biomarker of GFAP between attacks, but perhaps CSF measurements would be more sensitive. So, and I've slightly modified these now. Does inter-attack change occur, and if so, how frequently? We would say yes, but I think the frequency is still unclear. Can it be detected by MRI? Yes, but as we've seen, not always. And there are also other tools that we need to consider. Is it clinically meaningful? I think at this stage, we just don't have enough information to make a conclusion on that. Will it change practice? Perhaps, but further study, I think, is required. So should routine MRI surveillance be undertaken in patients with confirmed or suspected NMOSD or MOGAD to assess disease activity? I would favour the answer no, and I would encourage the same from everyone listening. What I think we need is multimodal, longitudinal studies to better understand the attack-independent changes that occur over time in NMO and MOGAD. Thank you.
Thank you, Dr. Huda. Can I please open up the discussion and first ask Professor Friedman-Paul to give his rebuttal and comments?
So thank you very much, Saif, for your excellent presentation. And I saw that we have cited more or less the same papers when preparing our presentation, which I think is fully justified and explains the situation you nicely summarized on your last slide. So I do think that we have an issue with prospective longitudinal imaging studies, and this pertains both to MRI, but also OCT and other electrophysiological investigations, such as perhaps VEP. So we do not fully understand the correlation between a covert tissue damage that does occur in NMOSD and MOGAD, that is now quite clear, I think, and maybe subtle clinical sequelae. So we would need regular cognitive testing. We would need more sophisticated visual testing to detect the effects of subclinical visual pathway damage, etc., etc. So, and as long as we do not have these prospective follow-up studies, I would indeed, from a clinical standpoint, probably refrain from performing frequent MRIs, because we do not know how this would inform treatment decisions. I would still base my clinical decisions upon clinical attacks and clinical symptoms reported by patients and detectable upon neurological examination. But as you have also nicely presented, a subtle or very small new T2 or flare lesion on a brain MRI at this stage of knowledge would be rather confusing than helping us to make a good treatment decisions. And with that, back to you, Abhijit.
Thank you, Friedman. Can I ask Dr. Saif Huda if you have any additional comments to make before we go to voting?
Yeah, thank you, Abhijit. I mean, it's a pleasure to be here and to be invited. Thank you, and to be sparring against Professor Paul, which is a great honor for me. And some excellent points have been raised by Friedman. And I think that it's right that we should, at this stage, base our management on the clinical side of things. And we mustn't run into the risk of jumping to doing things the way we do in MS. We've spent many, many years trying to show that NMO is a different disease to MS. And I think it would be a folly to sort of jump back into practices that, you know, are very justified in MS and extrapolate those to NMO when we have very good reasons to think that these two diseases are very different. I think that the safety side of things is an interesting one. The GAD enhancement changes with the inebilizumab trial are very intriguing. I think we really need to unpick that more. But we always have to bear in mind that if we were going to do lots of GAD scans, GAD does deposit in the dentate and in the brain, essentially. So that's a consideration. And whether these changes that we see asymptomatically, we need to understand what they mean. Are they small vessel ischemic changes? And I agree that it can be difficult to know what to do with that clinically. Of course, if you see a new lesion in an eloquent area, one's probably going to act, but that doesn't seem to happen very often from the data that we have. And I think listening to the MS talks yesterday, there was a lot about what is a sensitive measure to detect NIDA, and how do you define that? And do we use EDSS? Well, we know that's flawed in many ways. And I think here we see that MRI has a utility, but we see there are other measures that are very important that we need to better understand. So this idea of changes in OCT, changes in VEP, changes in volumetric imaging over time, I think putting that all together and trying to understand that in a well-designed, internationally collaborative study would be the best way to do that, rather than how we change our clinical practice and then sort of end up in a muddle about it.
Okay. Any further comment, Professor Friedman, Paul?
No, I think Saif has nicely summarized the current state of knowledge and the knowledge gaps that we have identified in both presentations. So I'm happy to proceed.
Okay. There's one question. I think we do see the MRI surveillance being an extension to the current practice in multiple sclerosis, which obviously took many years to develop and refine. So the question here is, in terms of predicting disease progression and relapse, you may have to look at the treatment that you have deployed in these patients. So it's wonderful if you have access to the newly approved treatments for NMOSD, like eculizumab, which reliably reduces relapse rates. But the truth is that kind of treatment, which is quite expensive, is not easily accessible to very many patients in many parts of the world, where you may have to still rely on relatively inexpensive treatment options, may not even have access to anti-CD20 generic version of rituximab. So my question is, in an ideal circumstances, yes, we may have the luxury with an eculizumab treated patient to know that, look, the relapses will go and we may not have to worry a lot. But when you are using less efficacious options, let's say simple prednisolone and azathioprine, would MRI monitoring give you better understanding of disease activity to escalate the treatment if you have to?
I mean, if I may start.
Yes, Professor Paul. I would like you to start, and then I will ask Dr. Huda to comment.
Okay, thank you. And then I'll hand this over to Saif. So I think, again, my answer would be a clear no, because if we have a patient on prednisolone and azathioprine, and he or she is doing clinically well without overt attacks, without deterioration of neurological function, would an MRI in any way help with switching or escalating or having the patient stay on treatment with any treatment decision? The answer is probably no, because again, if we see an UT2 lesion in a 45-year-old patient with concomitant hypertension, what does this mean? Is this an indication that NMOSD is progressing or evolving, or is this a T2 lesion that emerges from the hypertensive condition the patient has? We don't know. So again, and especially in a situation you rightfully raised, Abhijit, that this is a circumstance most likely in less affluent countries that cannot afford drugs such as eculizumab. Okay, would it make sense to allocate resources to an MRI that also costs money? That does not truly help us with treatment decisions. But I'm happy to hear Saif's position on this as well.
Yeah, I think that's beautifully summarized. Thanks, Abhijit. I think it's beautifully summarized. I'd agree with all those points entirely. And I think in some ways, NMO, we're quite fortunate as neurologists because the attacks declare themselves quite clearly a lot of the time. So subtlety isn't part of the condition generally. I mean, we know that when people are on treatment, the attacks can be more subtle, but clinically they usually are quite evident. So I think that helps us in that situation. I sort of feel quite strongly we should be driven clinically until we know more.
Thank you, Dr. Huda. So I think we can call for the post-debate voting. So to the audience, would you please vote those who favor? Okay, so I think there is a swing. Am I right in saying that 40% have voted yes and 60% no? Let's have a look. Yes, so I think previously it was 65% voting yes and 35% no. So that has reversed. So there is a swing, and Dr. Huda's presentation has carried and the motion has been defeated. But thank you both, Friedman and Say, for your excellent presentations. And I'm sure the audience will take home the messages you have so clearly shown to them. And also thank you for attending the meeting.